Good evening. Today I want to go over a very practical paper on the role of 18-FFD-GPET/CT in infective endocarditis, specifically whether it helps us find extracardiac complications that actually change management. This study looked at one of the biggest challenges in endocarditis care: metastatic septic complications outside the heart. We all know these complications matter. They drive morbidity, they drive procedures, and they can easily be missed if you only look where symptoms point you. The investigators asked a very simple but very important question. If you perform 18-FFD-GPET/CT in patients with suspected infective endocarditis, do you find extracardiac complications that lead to more source control interventions than conventional workup alone? This was a prospective registry study from Amsterdam UMC. They included adults with possible or definite infective endocarditis by 2015 ESC criteria from 2016 through 2021. In total, they analyzed 252 patients. Of those, 152 underwent PET/CT within 28 days of starting effective antibiotics, and 100 served as the control group without PET/CT. The median time from antibiotic start to PET/CT was 8 days. Their primary outcome was the number of source control interventions for extracardiac complications. They also looked at number needed to scan, predictors of PET-related interventions, antibiotic changes, and 90-day mortality while accounting for immortal time bias and confounding. Now to the results. First, extracardiac complications were extremely common. They were detected in 66% of the control group and 76.3% of the PET/CT group. In the PET/CT arm, conventional workup had already found 140 extracardiac complications in 87 patients. Then, PET/CT identified 193 possible additional findings. Of those, 131 were novel, and after follow-up and adjudication, 110 were considered truly new extracardiac complications. So PET/CT substantially increased detection of clinically relevant extracardiac disease. Second, and this is the main message, PET/CT translated into more source control. In the control group, conventional workup led to 18 source control interventions in 16 patients. In the PET/CT group, conventional workup led to 36 interventions in 17 patients, and PET/CT itself led to 21 additional interventions in 18 patients. The crude number needed to scan was 8. In other words, for about every 8 PET/CT scans performed, one additional patient underwent a source control intervention because of a PET/CT finding. After adjustment for confounders and correction for immortal time bias, PET/CT was associated with a significantly higher frequency of source control interventions, with an adjusted hazard ratio of 2.96. The model estimated about 19.8 interventions directly attributable to PET/CT. What kinds of complications did PET/CT help uncover? It was especially useful for vertebral osteomyelitis, pulmonary complications, skin and soft tissue abscesses, prosthetic material infections, and other musculoskeletal metastatic foci. Not surprisingly, PET/CT was much less helpful for the central nervous system. In fact, it detected essentially no novel CNS complications, which makes sense given the high background physiologic FDG uptake in the brain. So this is not a replacement for dedicated neuroimaging when CNS embolic disease is suspected. What kinds of interventions increased? Abscess drainage was the most common source control procedure. There were also more joint irrigations, pleural empyema drainages, and removals of infected prosthetic material in the PET/CT group. So this was not just more imaging for the sake of imaging, it led to actionable findings. PET/CT also changed other aspects of care. In 9.2% of patients, PET findings led to antibiotic modifications. That included longer duration of therapy, higher dosing, addition of a second antibiotic, and in one case, a switch from intravenous to oral therapy. PET/CT also led to reclassification from possible to definite endocarditis in 15 patients, especially in prosthetic valve endocarditis. That is an important diagnostic bonus. Now, Did all of this improve mortality? Not in this study. Crude mortality looked lower in the PET/CT group, but after correcting for immortal time bias and adjusting for confounders, there was no statistically significant difference in 90-day all-cause mortality. That is a key point. More detection and more source control, yes. Proven mortality reduction, not here. And what about the downsides? PET/CT was not perfect. Of the 131 possible new PET findings, 21 were later rejected. That means false positives or clinically irrelevant findings did occur. Those findings triggered 31 extra imaging studies and 24 specialist consultations. So PET/CT can create downstream work, cost, and noise. Also, this was a single-center observational study in a tertiary center, and PET/CT was performed at clinician discretion, so residual confounding is still possible. In the sensitivity analysis restricted to definite endocarditis, the association with more source control was no longer statistically significant, likely because the sample was smaller and event rates were lower. So, what is the practical takeaway? This paper supports 18 FFDG PET/CT as a clinically useful adjunct in suspected infective endocarditis when looking for occult extracardiac complications. It seems particularly valuable for uncovering metastatic foci that can be drained, debrided, or otherwise source-controlled. It also helps refine the diagnosis, especially in prosthetic valve disease. But it should not be seen as a magic test. It does not replace targeted imaging, especially for the CNS, and it comes with false positives and extra workup. Bottom line, in infective endocarditis, PET/CT appears to find what conventional workup can miss. And in this study, that translated into more source control interventions, with a number needed to scan of 8. That is a meaningful operational result, even though mortality benefit remains unproven.